Our next presenter is Dr. Fasching. He's going to be presenting our second talk on neoadjuvant paclitaxel olaparib in comparison with paclitaxel carboplatin in patients with HER2-negative breast cancer and homologous recombination deficiency, a long-term survival of the GERPAR-OLA study.
Thank you. First, I would like the organizing committee for selecting this analysis of this intergroup study for oral presentation. And it's a pleasure to present on behalf of the German Breast Group and the AJOB study group the long-term follow-up data of the GERPAR-OLA study. These are my disclosures. So the data concerning safety and the PCR rates have been reported previously. The randomized phase 2 GERPAR-OLA study investigated the neoadjuvant treatments olaparib plus paclitaxel followed by an anthracycline-based therapy and platinum plus paclitaxel followed by the same EC treatment in early breast cancer patients with HER2-negative homologous recombination deficiency tumors. The PCR rate that was previously reported in the olaparib arm was 55.1% and 48.6% in the platinum arm, and therefore were comparable. Olaparib, however, was significantly better tolerated than platinum. And here now we report the long-term survival data with a median follow-up of almost 50 months. The study included early-stage HER2-negative breast cancer patients that had a homologous recombination deficiency high tumor. And that was defined as patients with either having a known somatic or germline BRCA1 mutation, or that they would have a HRD score high in the tumor, defined as a MyChoice score of 42 or larger. Patients were treated with weekly paclitaxel and olaparib at a dose of 100 milligrams twice daily. The lower dose was chosen to make the study feasible with regard to toxicity. In the platinum arm, paclitaxel also was given weekly together with AOC2 carboplatin also weekly. Epirubicin cyclophosphamide 90 and 600 milligrams were allowed at a 2-week schedule or a 3-week schedule. 106 patients were randomized in a 2-to-1 ratio, and for follow-up analysis, 47 patients and 23 patients were available. For the interpretation of the data, it might be important to memorize that there was a disbalance with regard to nodal positivity. In the platinum arm, 45% of the patients had a positive nodal status, and in the olaparib arm, that was only 25%. Also, it's important to realize that the inclusion mechanism allowed both either a tumor or germline mutation or an HRD score high. Almost all patients had a tumor with a high HRD score. However, not all of them were mutated with regard to the BRCA genes. 46.2% had a mutation, and 43.4% did not have a BRCA1 or BRCA2 mutation. For the interpretation of the follow-up data, here again, the PCR rates according to BRCA mutation status. Almost all patients had a high HRD score, and in the mutated group, there was no difference with regard to PCR rates, both being 60%. In patients that did not have a BRCA mutation, the patients treated with olaparib had a PCR rate of 50%, and in the platinum arm of 37.5%. For this analysis, we looked at invasive disease-free survival, distant disease-free survival, and overall survival. The time to event endpoint analysis was planned with a median follow-up of 4 years and a follow-up completeness of 80%. Multiple testing was not considered. Also, realize that the event rate is really low with 18 IDFS events, 13 DDFS events, and 7 death events. These are the main results. The platinum arm had a 4-year invasive disease survival rate of 88.5%, and olaparib had a lower 4-year invasive disease-free survival rate of 76%. Adjusted for tumor mutation status and nodal status, this is equivalent to a hazard ratio of 3.6 with a wide confidence interval of 1.02 to 12.7. To interpret this data, here the same analysis with invasive disease-free survival as an endpoint stratified for germline or tumor BRCA mutation status. On the right side, these are the patients that have a germline or tumor mutation, and you can see that there's no indication for a difference between the platinum treatment arm and the olaparib treatment arm. However, on the right side, you see the patients that had no mutation in the tumor or the germline. Again, all of them were HRD score high, And there was a similar event rate for the olaparib-treated patients, but the patients treated with olaparib had an excellent prognosis. Looking at more subgroup analysis, there was no further subgroup that would indicate a difference. It was only the BRCA mutation status and maybe related to that the age, where you can see that patients with an age 40 or younger were rather on the left side in favor of the olaparib treatment. No of the tests for interaction yielded a positivity. For completeness, here are the other two endpoints, distant disease-free survival and overall survival. You can see that the direction of the effect was in the same direction. However, the difference between the randomization arms for this outcome analysis were a little bit smaller. So how do we interpret this study, keeping in mind it's a small study with a low event rate? Gaparola investigated the addition of olaparib and paclitaxel as part of neoadjuvant chemotherapy in HER2-negative early breast cancer patients with homologous recombination deficiency. To remember, PCR rates were not different between the treatment arms, and the IDFS, DDFS, and overall survival were numerically inferior with olaparib compared to platinum. The invasive disease-free survival, comparing the olaparib treatment arm and the platinum treatment arm in patients with a BRCA mutation, was, however, comparable. So therefore, it might be hypothesized that in patients with a mutation, olaparib could replace platinum, keeping in mind that the toxicity profile was more favorable. But in patients without a tumor or germline mutation, the platinum-containing neoadjuvant chemotherapy might be resulting in a superior outcome. If wanting to interpret for the clinic, of course, this data would have to be confirmed in larger clinical trials. I would like to acknowledge all patients and their families, all participating study sites. Our external collaboration partners, thank you, are listed on the left side, and on the right side, the hardworking team of the German Breast Group and the AJOB breast study groups. Thank you all for your attention.
Thank you, Dr. Fasching, for your presentation. Are there questions in the audience? Number 2?
Yes, thank you. Sykov from Rhode Island. I hope that these results will help correct the misapprehension that too many oncologists have that it is patients with BRCA2 mutations who benefit from the addition of carboplatin, whereas those with wild-type BRCA do not.
That could be one interpretation, yes. Again, we have to keep in mind the olaparib dose was low. We have a small sample size. With regard to the Mario test, it was developed at a time where there was not so much patient and biomaterial data available for olaparib patients. So the data needs to interpret it with caution. But yours could be one of them.
Thank you.
We have a question online. Are there other HRD mutations?
Well, while this data is difficult to interpret, the hypothesis that results from this data, I think, is quite clear. We have a scar in the tissue, it's HRD high, and obviously the ones where the BRCA mutation is the reason for that scar, the olaparib works well. But then we have tissues where we have the same scar, and there must be other reasons for that scar, and therefore we have to look at these other reasons for that scar, and I've seen already some of you in the audience that are already working on these translational research programs, but I don't have any data concerning that yet.
We have a question from the table.
So wonderful presentation, thank you. Maybe you alluded to this a little, but the numbers are small, I know, but any difference between germline mutation carriers and just somatic mutations?
We don't have that data,
Yeah.
I'm sorry. But there were, I mean, you have to keep in mind there's not many patients that have a tumor mutation and not a germline mutation. I think the percentage is much lower than in ovarian cancer, so it would be very difficult to get a sample size to actually answer that question. I would assume almost all of them had a germline mutation.